Kumar is a well-experienced medical oncologist, a hemato-oncologist, and BMT physician. He completed his DNB General Medicine from St. Martha's Hospital, Bengaluru. He's a consultant specializing in general medicine and medical oncology, providing high-quality personal levels of healthcare to patients in clinical environments. His medical skills resulting in years of successful patient care during hospitalization. His approach towards patient is very commendable, and his persistent in finding best treatment options available for the patients. He completed his postdoctoral DNB medical oncology from the prestigious Army Hospital Research and Referral Hospital, New Delhi. And he certified from the European Society of Medical Oncologists. He was awarded the MRCP UK in medical oncology in 2020. So he has various publications in national and international journals, and he has also presented various papers at various conferences. His expertise in managing the cancers of the breast, lung, GI tract, liver, genitourinary system, and sarcomas. His special interest in managing complex cancers, lymphomas, blood-related cancers, myeloma, and BMT. Sir, heading over the session to you to introduce today's session of SPOC.
Thank you for the kind introduction, Dr. Rashmi. So good evening to all of us. Before I introduce Dr. Pavan Sugur, I'd like to talk about SPOC. What is SPOC? It is a Society for Prevention of Cancer. On a sunny day, we were sitting having lunch with Dr. Nanda Rajneesh when this brilliant idea struck her that we've been working a lot and trying to how to treat cancer. We've been how to screen for cancer, but very few of us actually know how to prevent cancer. This is an enigma which has been there. So then came this brainchild where that we said that let us all put our brains together, let's brainstorm, and not brainstorm just on over lunch or over dinner. Let us brainstorm on a regular basis at multiple occasions, meet with more experts, talk to people, identify what are the tenets of cancer and see how we can prevent it in the society. Because like we say, a stitch in time saves 9, and something more important than is prevention is better than cure. So we at SPOC we envisage to see how we can prevent cancer in the society. Of course, we would like to catch it in its early stage and treat it, but can we move to a cancer-free society? Is it possible for us to identify what are exactly the touch points and then afterwards prevent them from causing cancer? And in this series, now after finishing lung, we are now moved to the GI tract. We'll be talking about esophageal cancers today. And we have a very young, smart and dashing surgical oncologist, Dr. Pavan Sugur, with us today. Dr. Pavan is an alumnus of Siddhartha Medical College. He did his MBBS. Then afterwards, from the prestigious MS Ramaya College, he finished his MS General Surgery, and then went to the world-famed Tata Memorial Hospital, where he did his surgical oncology MCH, and after which he also trained in colorectal fellowship. He had a colorectal fellowship in TMH as well. He has a keen interest in GI surgical oncology, along with HIPEC, that is hyperthermic intraperitoneal chemotherapy. This is again an advanced form of chemo and surgery for ovarian malignancies. So without much ado, I'd like to hand over the stage to Dr. Pavan Sugur, who's going to take us across the spectrum of how we can prevent esophageal cancer. Over to you, Dr. Sugur. We welcome you to the SPOC family.
Thank you so much, Dr. Rajiv. Thank you so much for your kind words. So do we start off now? Yeah. Do we start?
Yes, sir. You can start, sir.
Yeah. Good evening. It's a great pleasure being here. And I'm Dr. Pavan Sugur, surgical oncologist from Kidwai Memorial of Oncology, Bangalore. and I specialize in GI and colorectal surgery. At the outset, I would like to thank Dr. Nanda and the team SPOC for the opportunity and deeply appreciate their efforts, which is been the driving force for preventive oncology in the era of where we are finding cure. So my talk is focused on prevention of esophageal cancer. To begin with, we all are familiar with Charles Darwin, an English naturalist who gave us a compelling evidence about evolution and natural selection. To quote unquote him, adaptable to change is the essence of life. And this happens to be the same in all walks of life. And so is it in oncology. Much has changed over a period of time. Science has changed, mankind has changed, but yet biology of the disease still remains the king. This quote from Blake Cady is profound. It was true then and it is true now. Just to reiterate his words, in the fundamentals of oncology, biology is king, selection is queen, and the technical maneuvers are the prince and princess. So the technical maneuvers, what we are referring today in this context is the treatment strategies. And for the fact that we know preventive measures are an integral part of our treatment strategies. So all in all, the driving message is that and to come out as the strongest species, to evolve in, we all need to be open-ended with a mind frame to change. So in the next 20 minutes or so, I'll briefly cover upon the epidemiological aspects of the esophageal cancer, a brief note on histological subtypes, the risk factors, and possible preventive measures. So it's unfortunate to know that there's been a 600% increase in esophageal adenocarcinoma ever since 1975. It has become one of the most fastest growing type of a cancer in the United States. My talk is predominantly focused on esophageal adenocarcinoma because that is where we can make a difference with adapting to a lifestyle or adapting to a good diet. So predominantly I will be focusing on esophageal adenocarcinoma. To give you the facts and figures, annually around 6 lakhs individuals have been diagnosed of esophageal adenocarcinoma worldwide, of which close to 90% succumb to it. The reported annual cancer-related death because of esophageal carcinoma is 5.4 lakhs. And just to give you the pulse of the magnitude of the disease, for every death, for 18 cancer deaths, 1 cancer is attributed to the esophageal cancer. As per the Globocon 2020 statistics, esophageal cancer accounts for the 7th most common cancer and stands out as the 6th most cause of cancer-related death. It still remains a disease predominantly seen in low middle income countries, developing nations. It has gotten a small predilection for male gender. So if you look at this chart, a comparison between adenocarcinoma and squamous cell carcinoma, which is relevant to our context. I'm not going to go into the other subtypes of it. By and large, squamous cell carcinoma remains the most common histological variant worldwide. But however, adenocarcinoma stands out in the Western population. Countries like UK, Netherlands, US, adenocarcinoma is leading from front. Slowly, there's been a change in the developing nations, the so-called China, Iran. The incidence of adenocarcinoma is rising. The symptomology of secondary to an esophageal carcinoma can span from a simple heartburn, regurgitation, reflux, dysphagia, which can be a variable grades. There could be a reported weight loss either because of cancer cachexia or because of a secondary to a nutritional anemia element. So what are the risk factors we need to be aware of? Predominantly, there are 4 risk factors. One is a gastroesophageal reflux disease, Barrett's esophagus, obesity, and smoking. And I chose these particular 4 topics. This is where we can make a difference, because often these are pre-malignant conditions, and a good understanding and a good knowledge of this, we can revert the changes. There are few protective factors, H. pylori infection, aspirin and statins, which are shown to reduce the risk factors of esophageal adenocarcinoma. So what is GERD, or gastroesophageal reflux disease? Presence of stomach contents in the esophagus is a normal thing. But if it happens periodically, frequently, leading on to symptoms or complications, the term is tagged as a gastroesophageal reflux disease or a reflux. The predisposing factors which are attributed for GERD are dietary habits, predominantly consumption of deep fried food, chocolates, caffeine, high BMI, smoking, increased intra-abdominal pressure, which can be because of chronic cough, constipation, pregnancy, hiatal hernias, lower esophageal sphincter, which is lax, or a few to name. To give you a pulse of how common is gastroesophageal disease, annually 81 million Americans have been diagnosed of an GERD, of which 61 million people get treated with proton pump inhibitors, antacids, and H2 blockers. Approximately 10%, that is 6.7 million Americans, get an upper GI endoscopy for an evaluation of an GERD. The symptoms of GERD can be grouped into either a typical ones or an atypical ones. Typical ones are the one where we have a dyspepsia, heartburn, regurgitation, sensation of bloating, and insensitive to some foods and liquid. Atypical GERD are the ones where the symptoms are not classical, but you have an element of something like you have a persistent cough, or you might have been diagnosed of an asthma because of regurgitation, aspiration episodes, dental erosions, gum disease are few to name the symptoms of GERD, atypical GERD. So it's quintessential to understand the disease spectrum of the GERD. GERD can span from as simple as erosive esophagitis, which is seen in 10 to 30% of population, which can evolve into an stricturing esophagitis in 1 to 2%, might progress into a Barrett's esophagus in 10% of individuals. And there's a definitive positive correlation between a Barrett's esophagus and an adenocarcinoma, which I'll be covering up in my subsequent slides. So how is GERD related to esophageal adenocarcinoma? There's plethora of evidence to suggest that if an individual has a GERD symptom or a reflux symptom every day, the odds of having an esophageal adenocarcinoma is 7. And an individual has an GERD symptoms for more than 30 years of his life, the odds of developing an esophageal adenocarcinoma is close to 6. So in simple spoken language, earlier you have it, longer you have it, more you have it, GERD symptoms, higher the chance of you developing into an esophageal adenocarcinoma out of GERD. Let's go on to the second topic, which is obesity. Obesity is relevant all over the place. It's like a breathing air, you name it, you have it. It is the second most common environmental risk factor for cancer, second next to tobacco. And the prevalence of obesity has increased leaps and bounds since 1975. 13% of adult population are obese or were obese in 2016, and 18% of children were diagnosed of obese in 2016. So if you club these two numbers, close to 25% of world is filled with obesity. And to give you an estimate of obesity and esophageal adenocarcinoma, the odds ratio of being an obese and developing an esophageal adenocarcinoma is 2. Morbidly obese, as defined as an BMI of more than 40, puts an individual with an odds of 6. Again, overweight is also are coming up in the forum. We have not accounted for overweight. Overweight is defined as a measure of BMI less than 25%, and obesity as a BMI of more than 30, and morbid obesity as a more than 40%. So let's understand Barrett's esophagus. I'll just run a small clip about Barrett's esophagus. That's a stomach content which is regurgitating into the esophagus. So repeated regurgitations of food as well as that of the acid will predispose the lower third esophagus, which is lined by stratified squamous epithelium, into something called as an intestinal metaplasia, and where the stratified element of squamous is replaced by columnar lined epithelium. And over a period of time, with a repeated stress and inciting factor exposure, there is a transformation of Barrett's esophagus into an mild dysplasia, severe dysplasia, and malignancy. So why we need to know about Barrett's? Because Barrett's is a predisposing or a pre-malignant condition where preventive measures at appropriate juncture of life can revert the changes. So this is a word about obesity and its mechanism of how obesity predisposes for Barrett's esophagus. And you can see that illustration where there's a truncal obesity, that is a CAT scan with an pink highlighted visceral fat. This visceral fat acts on, has two mechanisms of action. Either it has got a humoral action or it has got an mechanical action. When I mean humoral action, it predisposes or it activates n number of inflammatory responses which trigger the neoplastic course in the downstream. And the mechanical cause, we all are familiar. Just to speak in simple language, a good pad of fat at the stomach, and when we lie down, we always feel that regurgitation which keeps up happening. So obesity is definitely predisposes for GERD, and GERD over a period of time changes into Barrett's esophagus. So there's a positive correlation between both of them. This is a conceptualization of obesity pathophysiology in a simple language. Every arrow which is interlinked has a plethora of evidence to prove that obesity is positively linked to GERD, and aftermath of GERD is a Barrett's and esophageal adenocarcinoma. This is something interesting. Let me draw your attention to H. pylori infection. So H. pylori infection is strongly correlated with gastric ulcers, or what we call it as an acid peptic disease, and chronic atrophic gastritis, maltomas, and gastric carcinomas. The sequel which happens to H. pylori infection is that you have an H. pylori infection, there's a gastritis over a period of time, there is atrophic gastritis, so this acid secretion is less. So an individual who's got an H. pylori infection has got an element of a gastroesophageal reflex. The reflex is not so obnoxious as that of other individuals because the acid component in the reflex is less. So that means that H. pylori has shown an inverse proportion with esophageal adenocarcinoma. And I don't mean to say that infect every other person with H. pylori for prevention of esophageal adenocarcinoma, but we should be cognizant with the facts and figures that H. pylori infection may reduce the risk of esophageal adenocarcinoma. So to know how to prevent, we need to know how to implement and way to implement these prevention as checkpoints. So to reiterate, an individual who is being exposed with inciting factors, either it transforms GERD into Barrett's esophagus or Barrett's esophagus to esophageal adenocarcinoma, or theoretically there can be a direct transformation of normal mucosa of the esophagus to esophageal adenocarcinoma, which can happen, but it is a rare entity. So do we have data on it to say prevention make a difference in esophageal adenocarcinoma? Yes. So whenever we talk about prevention, we all are familiar and cognizant that there are three modalities of prevention, or three checkpoints of prevention. We have a primary prevention, we have a secondary prevention, and we have a tertiary prevention. It is very important to have a data. When I mean data, I mean epidemiological data to risk stratify the individuals so that we can implement a preventive measure, which can be a possible opportunity screening or a chemo prevention. So, well, in this context, we have epidemiological data which says that male gender and white race have a higher tendency for developing a Barrett's esophagus and has got a very little predilection for Barrett's esophagus transforming into esophageal adenocarcinoma. So does it have any clinical implications? Yes, it has clinical implications, and I'll be coming to it in the later part of the discussion. We also know that there's a strong correlation between obesity reflux into Barrett's esophagus, but the correlation of Barrett's esophagus going into esophageal adenocarcinoma is less. So the primary preventive measures, what we can incorporate in our lifestyle for prevention of esophageal adenocarcinoma, especially gastroesophageal reflux disease coming out of the Barrett's esophagus, is we can keep our body weight to less than 25, to have a grazing method of food eating where 5 small frequent meals are being taken. This is predominantly for patients who are suffering from a gastroesophageal reflux disease, and avoidance of food which are having high fats, especially like a deep fried food, chocolates, caffeine, refraining from going to bed within 3 to 4 hours after the meal, elevating the head of the bed end has shown to prevent reflux disease. Every effort to refrain from smoking, alcohol in moderation is good, and the most important is physical activity. Physical activity in any form for a half an hour to an hour day can definitely reduce the BMI and put the an individual into a good lifestyle. So all these elements fit into patients who have been diagnosed of a gastroesophageal reflux disease and who have an proportional risk of progressing into Barrett's esophagus and aftermath into esophageal adenocarcinoma. So I would say these are the primary preventive measures what we can put forth as an first checkpoint in prevention. So let's move on to the second point, which is a chemo prevention. It's very interesting to know that proton pump inhibitors have reduced development of adenocarcinoma and Barrett's esophagus in almost 70% of individuals. That's a remarkable incidence. And also it is noted that the progression of Barrett's into cancer is reduced, apart from individuals developing the disease interval is also progressed, is also widened. So definitely proton pump inhibitors at a right point in time is a chemopreventive measure for individuals with Barrett's who have been diagnosed with Barrett's. So now it's let me draw your attention that proton pump inhibitors, does it prevent Barrett's? It is unclear, but proton pump inhibitors prevents progression of Barrett's into the esophageal adenocarcinoma. So that's an data which is coming from GUT 2014, a good journal with a high impact factor. So this could be a second checkpoint for progression of Barrett's into the esophageal adenocarcinoma. So where do we stand with aspirin? So aspirin has shown, or NSAIDs have shown, to reduce the risk of development of Barrett's. So again, we have one more chemopreventive measure. A simple NSAIDs, which is over-the-counter available medicine, makes a difference. Yes, it has to be consulted and with a physician and then administered. So there are two drugs in our armamentarium. One is NSAIDs, which prevents development of Barrett's, and we have the other drug which prevents progression of Barrett's into the esophageal adenocarcinoma, making a difference to an individual with GERD. So once diagnosed with the Barrett's, how do we go about? So there was a limited science in the yesteryears, but with evolution of imaging modalities, when I mean imaging modalities, I refer to endoscopies. These days, Barrett's esophagus are picked up quite early in their manifestation stage. So we know that, just to reiterate, GERD progressing into Barrett's, then Barrett's progresses slowly to an element called as a low-grade dysplasia. Then it goes into a phase of high-grade dysplasia before it completely transforms into an esophageal adenocarcinoma. The incidence of Barrett's transforming into esophageal adenocarcinoma is, the risk is 0.1% per year. So we should be cognizant with this. The modalities what we have, either to detect Barrett's early in the initial stages, be it low-grade dysplasia or high-grade dysplasia, or high-resolution endoscopes, chromoendoscopes, autofluorescence, narrowband imaging, and fluorescence or microendoscope are a few to name. American College of Physicians has put forth a guidelines for endoscopic evaluation of gastroesophageal reflux disease. And if you note here, a male gender more than 50 years with chronic symptoms of GERD, endoscopy is strongly recommended at an interval of 3 to 5 years, on a notion that Barrett's can be picked up quite early in the initial stages. And any individual who's got an history of a Barrett's esophagus or a diagnosed case of a Barrett's esophagus, a surveillance endoscopy is recommended at an interval of 3 to 5 years. So we have diagnosed a case of a Barrett's either by opportunistic screening or by we have picked it up on a routine endoscope. So do we have any preventive measures to take care of this so that it does not transform into adenocarcinoma? Yes. This is a randomized controlled trial published in the NEGM, 2-arm studies, radiofrequency ablation versus a sham treatment. Apparently, the numbers are quite high. With a radiofrequency ablation, which is just an office procedure where an endoscope is being utilized for a radiofrequency, for an ablation of an Barrett's, which was not prevalent in the yesteryears, which is gaining momentum in the recent years, has shown complete eradication of intestinal metaplasia with an radiofrequency ablation to a tune of 77%, and these numbers are remarkable. So what do we have beyond lifestyle modification, beyond chemoprevention, beyond radiofrequency ablation? We have surgical modalities, and this is the last modality to be considered while managing the predisposing factors. So we have nicense fundoplications, we have an transoral endoscopic fundoplications, and we can augment the lower esophageal sphincters by magnetic sphincters. So these all are reserved in the later part of it. So my take-home messages are that primary preventive measures like lifestyle modifications, dietary regulations can make a difference in individuals who have been having gastroesophageal reflux disease. Secondary preventive measures like opportunistic screening or chemoprevention for already cases with GERD with an Barrett's esophagus makes a difference. Tertiary preventive measures like interventions either by radiofrequency ablation or surgical modalities can definitely make a difference in the progression to esophageal adenocarcinoma. And please be aware of the fact that Barrett's surveillance may detect cancer earlier, and as we all say, like cancer detected earlier, better is the cure. So cancer detected on surveillance have a better outcome. So I close my discussion on the preventive modalities with these comments.
Thank you, sir, for that very informative session. Now, attendees, if you have any queries or questions, sir will clear it now. Okay, so if you all have any questions later as well, we have a recorded version of the webinar available, and also sir's mail ID will be available, so you can ask him any queries or questions if you all have. I would like to thank Nanda ma'am for this wonderful opportunity, and I would like to thank one and all for all this patient time of y'all to listen to our webinar, and thank you for our wonderful speakers. For good evening ahead. Thank you. Thank you, sir.
Thank you so much, Rashmi. Thank you, Dr. Nanda. Thank you, Dr. Rajiv. Right.